This lecture is a part of the Cardiology Department, Cairo University e-learning program, and it covers the subject of supraventricular tachycardias. I'm Emanuel Fares. I'm a lecturer of cardiology and a member of the EP and pacing service in Cairo University. These topics will be covered during the lecture: introduction and definition, epidemiology, classification, electrophysiological mechanisms, differential diagnosis, clinical presentation, acute management, long-term management, tachycardia-induced cardiomyopathy, and finally some key messages. We'll start by the definition. The term SVT literally indicates tachycardias which originate above the His bundle. However, that is not always the case, as in AV reentrant tachycardia, the ventricle is an integral part of the tachycardia circuit. So traditionally, SVT has been used to describe all kinds of tachycardias apart from ventricular tachycardia and atrial fibrillation. SVTs are quite prevalent, and the overall prevalence is 2.25 per 1,000 persons, and the incidence is 35 per 100,000 persons years. Women have a higher risk of developing SVT than men, and persons aged above 65 have more risk of developing SVTs than younger individuals. At the cath lab, AVNRT is the most frequent substrate treated after atrial fibrillation, followed by atrial flutter and AVRT. In the general population, the prevalence of a WPW pattern on ECG ranges from 0.15 to 0.25%, increasing to 0.55% among first-degree relatives of the affected patient. However, not all these patients go to develop SVT, and intermittent pre-excitation is not rare. Compared with the population, the pre-excitation population is generally younger, predominantly male, and has less comorbidities. The proportion of patients with AVRT decreases with age, while the proportion of those with AVNRT and atrial tachycardia increases with age. The incidence of atrial flutter in men is 2.5 times higher than of women and increases exponentially with age. Patients with flutter are more likely to have been smoker, have a longer PR interval during sinus rhythm, has history of myocardial infarction and history of heart failure. As we come to the classification, there is a conventional classification based on the mechanism of the tachycardia and a clinical classification based on the QRS duration. Conventionally, SVT can be classified into atrial tachycardias, and these include sinus tachycardia, focal and multifocal atrial tachycardia, macro-reentrant atrial tachycardia, and these include the cavo-tricuspid isthmus, CTI, dependent atrial flutter, which can be typical or atypical, and the non-cavo tricuspid isthmus dependent flutter that can originate in the right atrium or the left atrium. The third category are AV junctional tachycardias, with the most famous being the AV nodal reentrant tachycardia or AVNRT, and this one can be typical most commonly or atypical, and we'll come to this in the following slides, and the non-reentrant junctional tachycardia, which is an uncommon tachycardia. The fourth category are atrioventricular reentrant tachycardia or accessory pathway mediated tachycardias, which can be orthodromic, including the PJRT or the permanent junctional reciprocating tachycardia, or antidromic with retrograde conduction through the AV node or rarely over another pathway. Based on the QRS duration, SVT can be classified into narrow complex tachycardias with a duration less than 120 milliseconds, or less commonly a wide QRS complex of more than 120 millisecond duration. The narrow complex tachycardias includes all forms of SVT, those originating from the atria including sinus tachycardia, focal atrial tachycardia, atrial flutter, those originating from the AV junction like AVNRT or junctional ectopic tachycardia, accessory pathway mediated tachycardia, and rare forms of VT have a narrow complex that's exceptional cause of VT with narrow complex if they originate from the high septum near the origin of the His bundle. As for the wide QRS tachycardias, they are usually ventricular of origin, and less common causes include the ventricular paced rhythm with tachycardia like pacemaker mediated tachycardia, Accessory pathway mediated tachycardia if they are of the antidromic type, or any SVT with in the presence of pre-excitation or aberration or bundle branch block that can be pre-existing or rate dependent. And sometimes if there are electrolyte disturbance or the patient receiving antiarrhythmic drugs of the class 1A or 1C antiarrhythmic drugs, they have an SVT with a wide QRS complex. So most of the SVT are narrow complex tachycardias, with few exceptions that can present with a wide complex, while ventricular tachycardias are usually of wide QRS duration, with few exceptions like idiopathic VT arising from the high set. Now we come to the electrophysiologic mechanisms underlying SVTs. These mechanisms do not apply only for SVT, they can also apply to VT and atrial fibrillation. And most tachycardias presenting can be due to disorders of impulse generation or re-entry. The disorders of impulse generation are also called non-reentrant or focal. And the reason for these tachycardias are: 1, abnormal automaticity, which can occur in non-pacemaker cells through a mechanism similar to the physiologic automaticity of the pacemaker cells, or triggered activity, where there are oscillations of the membrane potentials named early or delayed after depolarization if they happen during phase 3 or phase 4 of the cardiac action potential, and these can lead to initiation of arrhythmias. Few of SVT can arise due to these causes, and these include the sinus tachycardia, focal and multifocal atrial tachycardia, and the focal junctional tachycardia. The second mechanism for initiation of tachycardia is re-entry, where arrhythmias arise within myocardial regions that were previously activated in propagation and re-excite regions that have already recovered excitability. Classic examples include the AVNRT, AVRT, and macro-reentrant tachycardia, including atrial flutter. The mechanism of AVNRT is a classic example of re-entry. In up to 25% of the normal population, the AV node has dual physiology. The dual physiology means that as the impulse is traveling during sinus rhythm from the atrium and it reaches the AV node, it can travel down two pathways: a fast pathway that conducts faster but reaches refractoriness earlier, and a slow pathway that conducts slowly and have a longer refractory period, and then there is a lower common pathway to reach the ventricle. So during sinus rhythm, most of the impulses are traveling down the fast pathway. However, if there is a PAC and it reaches the AV node while the fast pathway is still refractory from the previously conducted beat, this impulse travels through the slow pathway and it reaches the lower common pathway at the time that the fast pathway can regain conduction. And this results in an atrial echo beat with an inverted P wave at the end of the QRS. If the conditions are right, this results in a re-entrant tachycardia where the impulse travels from the atrium to the ventricle over the slow pathway and then goes up through the fast pathway from the ventricle to the atrium, and thus propagating tachycardia. Depending on which of the slow or the fast pathway used by the signal to travel from the atria to the ventricle or from the ventricle to the atria, AVNRT can be either typical or atypical. The typical form of AVNRT, or the slow-fast AVNRT, which represents 95% of cases, in this type, the signal travels from the atrium to the ventricle over the slow pathway and from the ventricle to the atrium over the fast pathway, with resultant P wave, an inverted retrograde P wave at the end of the QRS complex. The atypical form of AVNRT, which is sometimes called the fast-slow or slow-slow AVNRT, the impulse travels via the fast pathway to the ventricle and returns to the slow pathway to the atria, and the retrograde P waves appear way behind the QRS. and this represents less than 10% of all patients. Another example of re-entry is accessory pathway mediated tachycardias. During sinus rhythm in patients who have an accessory pathway, the signal travels from the atrium to the ventricle through the AV node and also through the accessory pathway. And the resultant QRS complex is a result of fusion between the two signals traveling through the AV node and the pathway. The rapid conduction through the accessory pathway is responsible for the short PR interval and the delta wave at the beginning of the QRS complex. However, if there is a PAC that comes at a time where the accessory pathway is refractory and travels down the AV node, it can go up again to the atrium through the accessory pathway after it recovers its excitability. And this form of AVRT is called orthodromic AVRT. This one travels antigradely from the atrium to the ventricle through the AV node, resulting in a narrow QRS complex or a narrow complex SVT, and then travels retrogradely from the ventricle to the atrium through the accessory pathway. And this is the most common form of AVRT. The less common form of AVRT is antidromic AVRT, in which the signal travels antigradely from the atrium to the ventricle through the accessory pathway and then retrogradely through the AV node, or even less commonly through another accessory pathway. The resultant QRS complex is maximally pre-excited. It looks wide and bizarre configuration due to activation of the ventricle through the accessory pathway rather than the normal AV nodal axis. Identification of the nature of SVT from the surface electrogram. We can use this algorithm provided by the European Society of Cardiology. First, we will look for how regular is the tachycardia. An irregular tachycardia with a narrow complex is most probably atrial fibrillation. Less commonly, it can be focal atrial tachycardia or flatter with variable AV block, or a multifocal atrial tachycardia. In case of focal or multifocal atrial tachycardia, P waves of the same morphology in focal atrial tachycardia or variable morphology as in multifocal atrial tachycardia can be seen. In case of atrial flutter with variable block, the sawtooth appearance of the baseline between the QRS complexes will guide the diagnosis. However, if it's regular, as in most cases, you can look for a visible P wave. In most cases, the P waves will not be visible, and in that case, you can go for a diagnosis of a typical AV nodal entrant tachycardia. Other causes of SVT can also be present, but it's less common to not see the P wave. So if you see a P wave, you look for AV dissociation. If there are more P's than V's, as in atrial flutter, atrial tachycardia, or if there are more V's than A's, then it's ventricular tachycardia. Less commonly, you can find AV dissociation with AVNRT and with atrial tachycardia. If you can still see a P wave and the atrial and the ventricular rates are the same, you try to measure the RP interval. And classically, SVT can be classified into short RP tachycardia or long RP tachycardia. Short RP tachycardia is defined as the RP interval being shorter than the PR interval, which means that the P wave is present closer to the QRS complex of one beat than the PR interval of the following beat. The most common cause for a short RP tachycardia are typical AVNRT, especially if the RP interval is less than 90 milliseconds. If it's slightly more than 90 milliseconds, AVRT is more commonly diagnosed, or atrial tachycardia. If it's a very long RP, which means that the RP is more than the PR, sinus tachycardia, focal atrial tachycardia, some forms of AV reentrant tachycardia, and atypical AV nodal reentrant tachycardia can be diagnosed. If a diagnosis cannot be reached from the surface ECG, some maneuvers can be done, like the vagal maneuvers or administration of adenosine. Both procedures can have a diagnostic value and a therapeutic value as well. According to the response that may guide the diagnosis, usually if there is no effect, that's due to an inadequate dose or inadequate delivery, as adenosine has to be given in a certain fashion that will be discussed in a few slides. High septal VT does not respond to adenosine. However, the other responses are gradual slowing than reacceleration that occurs in sinus tachycardia, in automatic focal tachycardias, atrial tachycardia. If there is sudden termination, that means that there is block at the level of the AV node. That is more common with AVNRT, AVRT, and some forms of focal atrial tachycardia. If the atrial tachycardia persists with a high-grade AV block, that occurs with atrial flutter, macro-reentrant atrial tachycardia, and focal atrial tachycardia. This ECG represents a response of SVT to adenosine. In the left half of the tracing, you can see a narrow complex SVT with a one-to-one association between the V and the A. We can see a retrograde P wave a few, like 60 milliseconds away from the QRS complex, which points the diagnosis to AVNRT. As adenosine is administered, you can see that there is sudden termination of the tachycardia with a restoration of sinus rhythm. That's another tracing demonstrating the effect of adenosine. In the left half, we can see supraventricular tachycardia. The complex is wide, so it's a wide complex tachycardia. However, we can give the adenosine still, and the response was development of higher grade of AV block, which uncovered atrial flutter, denoting that atrial flutter is the origin of this tachycardia. This slide is divided into three columns. The first column represents the free-running tachycardia. The second column represents response to adenosine, and the third one represents the patient in sinus rhythm. In the first row, which represents AVNRT, the free-running tachycardia is narrow complex with a one-to-one VA association, and we can detect a retrograde P wave at the end of the QRS complex, causing a pseudo-R deflection. The response to adenosine is sudden termination of the tachycardia with restoration of sinus rhythm. In the second column, which represents orthodromic AVRT, the SVT is narrow complex. We cannot really detect or determine the site of the retrograde P wave, and this is not uncommon with SVT. The response to adenosine was termination of the SVT with restoration of sinus rhythm. In sinus rhythm, we can see that there is a short PR interval with a delta wave at the start of the QRS complex, indicating that an accessory pathway was the mechanism of this tachycardia. The third row represents an atrial tachycardia. It's a narrow complex tachycardia with the QRS complex less than 120 milliseconds, with a one-to-one association between the V and the A, and we can clearly see that that is a long RP tachycardia with the P wave closer to the second QRS complex than the previous one. The response to adenosine is classic. There is development of higher grade of AV block, which uncovers the HL activity. We can see multiple, like 4 P waves with an abnormal morphology different than that of sinus rhythm. And when we compare it to the sinus rhythm ECG in the third column. In the fourth row, that represents atrial flutter. That's an easy diagnosis from the start because there is a 2-to-1 block occurring during tachycardia. With administration of adenosine, this developed into a higher grade of AV block, which is clearly different from the sinus rhythm of this patient. Wide complex tachycardias with a QRS duration more than 120 milliseconds are most commonly ventricular tachycardia, more than 80%. However, a smaller subset of SVTs can present with a wide complex, the most common being SVT with bundle branch block aberration, which represent 15%. This can be due to a pre-existing bundle branch block or development of aberrancy during the tachycardia, which is more commonly a right bundle branch block pattern. The second group of wide complex SVT is a tachycardia occurring with antegrade conduction over an accessory pathway, pre-excited SVT, which participates in the circuit that's called antidromic AVNRT, or is a bystander during AF, focal atrial tachycardia, atrial flutter, or less commonly AVNRT, meaning that the patient has an SVT like atrial tachycardia or an atrial flutter or atrial fibrillation. However, the accessory pathway conducts that tachycardia to the ventricle, resulting in a wide complex without being an integral part of the circuit of the tachycardia. The third cause of a wide complex SVT, which is a rare cause, is development of widening of the QRS interval due to drugs or electrolyte imbalance, most famously occurring with class 1A and 1C drugs. Another form of a wide complex tachycardia that is not caused by the ventricle, not ventricular in origin, or caused by an SVT is development of a pacemaker-related tachycardia, so-called endless loop tachycardia or artifacts. We come now to the clinical presentation of SVT. So most common presenting symptom is palpitations, which can be associated with fatigue, lightheadedness, chest discomfort, dyspnea. The sudden onset and termination point to a diagnosis of AVNRT or AVRT. So occurrence of dyspnea or symptoms of heart failure can occur due if the patient has developed tachycardiomyopathy or has a pre-existing heart disease. Lightheadedness, pre-syncope or syncope are less common presentations than in VT or with other bradycardias and tend to be associated with presentation in older individuals. The acute management of narrow QRS tachycardia in the absence of an established diagnosis is straightforward. If there is hemodynamic instability, then a synchronized DC cardioversion is performed. If not, we should try vagal maneuvers or IV adenosine. These two procedures have a diagnostic as well as a therapeutic importance. If adenosine is not effective, we can try verapamil, diltiazem, or IV beta blockers. And if all failed, we can go for synchronized cardioversion anyway. Vagal maneuvers can terminate about up to 50% of the SVT, as this include two procedures: the carotid sinus massage, which is performed with a patient's neck in an extended position with the head turned away from the side to which pressure is applied. Pressure should be always applied on one side to avoid bilateral pressure, and should be limited to 5 seconds and should be avoided in patients with previous TIAs or stroke and in patients with carotid bruits. The Valsalva maneuver, and if it's to be standardized, you can tell the patient to blow in a 10 milliliter syringe with enough force to move the plunger, or changing from semi-recumbent to supine position with passive leg raise, the so-called modified Valsalva maneuver. These two procedures cause reflex stimulation of the vagus nerve, leading to release of acetylcholine, which slows down the electric conduction in the AV node. Adenosine is given in a 6 to 18 milligram IV bolus. This drug acts through the cardiac adenosine A1 receptors. Its electrophysiological effect is demonstrated by prolongation of the AV conduction. In the EP CAS lab, we can measure prolongation of the AH interval, but no effect on the HV interval. It means that it has a suprahisian effect, resulting in a transient AV block that is responsible for tachycardia termination in re-entrant tachycardias that includes the AV node. Injection of adenosine to be effective should be as a rapid bolus followed by immediate saline flush in a large vein. The dosing should be incremental, starting at 6 mg followed by 12 mg, and 18 mg dose can also be used. Adenosine has a very short plasma half-life due to enzymatic deamination being achieved in seconds, with end organ clinical effects complete within 20 to 30 seconds, so repeat administration is safe within 1 minute of the last dose. Other clinically important effects of adenosine administration include depression of the sinoatrial node function, so it should be given with caution in sinus node disease. AF may occur and appears more commonly associated with AVRTs and AVNRT. Clinically important bronchoconstriction is a rare occurrence in patients receiving IV adenosine for SVT. As for the acute therapy of wide complex tachycardia in the absence of an established diagnosis, should follow the rule that a wide complex tachycardia is usually a ventricular tachycardia in 80% of cases. So drugs which inhibit the myocardium like calcium channel blockers should be avoided. So if there is hemodynamic instability, you go directly for a synchronized cardioversion. If not, you can try the vagal maneuvers or IV adenosine. And if ineffective, you go for IV prokinamide, which unfortunately is not available in this country, or IV amiodarone. And if ineffective, you go to synchronized cardioversion. Now we will come to therapy of specific types of tachycardia. In cases of if SVT proves to be caused by sinus tachycardia, usually we look for reversible causes like fever, anemia, hyperthyroidism, pregnancy, too much caffeine, too much smoking, and we go for treatment of these reversible causes. If it's ineffective, you can try drug therapy with ivabradine or a beta blocker. If still symptomatic or there is sinus node reentry, which is a special form of sinus tachycardia, you can try a combination of the two drugs. And if still not effective, you can try a calcium channel blocker. And at the end, you can do like sinus node modification by catheter ablation. As for the other causes of SVT, the first line of therapy, if the episodes are recurrent or incessant, is to go for catheter ablation, as that's a class 1 indication. However, if the patient does not desire to do catheter ablation, or while waiting for catheter ablation, drug therapy can be given in the form of a beta blocker or a calcium channel blocker, and if those fail, another antiarrhythmic drug can be used. It is to be noted that amiodarone can only be used in patients with atrial tachycardia under very specific conditions and for short duration of time to avoid the development of side effects. The same applies for atrial flutter and macro-reentrant atrial tachycardia, where catheter ablation is the first line of choice in symptomatic and recurrent cases, especially if the flutter proved to be CTI dependent. The choice of catheter ablation for treatment of SVT is due to the high success rate, which exceeds 95% in case of CTI atrial flutter and AVNRT, and around 92% for AVRT, with 85% for focal atrial tachycardia, with a very low recurrence rate, except in cases of atrial tachycardia where recurrence can occur in up to 1/5 of the patients, in addition to the very low complication and very low mortality rates. And now we will discuss with a few details about the accessory pathways. Accessory pathways are not all the same. They can be classified according to the sites of origin and insertion. Most accessory pathways are atrioventricular. It's usually a very discrete band of tissues connecting the atrium and the ventricle directly over the mitral or the tricuspid annuli. Usually 60% are left-sided, 1/4 are septal, and 15% are right-sided. There is a rare type of accessory pathways called atriovesicular or Mahaim fibers, and we will give a few slides about this later in the presentation. Another classification based on the direction of conduction. Usually accessory pathways are bidirectional, i.e. they can conduct from the atrium to the ventricle or from the ventricle to the atrium. Very rarely a pathway can conduct only antegradely or retrogradely. In this case, it will not have manifest pre-excitation on the ECG, and we can call it a concealed accessory pathway. Based on the conduction property, most accessory pathways are non-decremental, which means that with increasing heart rate, they continue to conduct at the same speed, unlike the AV node, which shows decremental conduction. Very rarely, pathways have decremental conduction properties. Based on their numbers, they can be a single or multiple. Mahaim pathways are an uncommon form of accessory pathways. 80% are atriovesicular. They arise as a lateral tricuspid annulus. They have a proximal insertion into the atrium, and they run along intracardiac course and insert into the distal right bundle, often with arborization. These pathways have very unique properties. They conduct only antigradally, and they have decremental conduction property. It's like extranodal tissues located on the lateral tricuspid annulus. The resultant tachycardia is an antidromic AVRT with antigrade conduction over the Mahaim pathway and retrograde conduction over the AV node. Here is an example of Mahaim tachycardia. This is a wide complex tachycardia that has a left bundle branch block morphology and a superior axis. This is another example of a special form of AVRT, which is PJRT. PJRT stands for Permanent Junctional Reciprocating Tachycardia. This is an AVRT that is orthodromic. It goes from the atrium to the ventricle over the AV node and retrogradely from the ventricle to the atrium over decrementally conducting accessory pathway that is usually located on the septum. The ECG usually is a narrow complex tachycardia with a long RP, and the P waves are deeply inverted in the inferior leads and positive in V1. This is an example of pre-excited atrial fibrillation, a very fast heart rate associated with a wide complex of variable morphology and irregular. The variable morphology is due to various degrees of fusion of conduction over the AV node and the accessory pathway. Most cases of pre-excited atrial fibrillation are associated with hemodynamic instability due to the very rapid conduction over the accessory pathway, and in this case, termination by synchronized cardioversion is the treatment of choice, and all AV nodal blocking agents should be avoided because they increase the conduction over the accessory pathway. In the less common conditions where the patients are hemodynamically stable, intravenous ibutylide or prokenamide can be given. What about patients who have pre-excitation in the surface ECG and are asymptomatic? Most of these patients will go through life without any clinical events. The most common arrhythmia in WPW syndrome is AVRT 80%, followed by a 20 to 30% incidence of AF. The sudden cardiac death risk associated with pre-excited atrial fibrillation is probably due to the very rapid conduction over the accessory pathway, resulting in ventricular fibrillation. The risk of this occurring is 2.4 per 1,000 person years. However, not all patients with asymptomatic pre-excitation have an increased risk of sudden cardiac death. Certain clinical and electrophysiologic features are associated with increased risk, and this include young age, inducibility of AVRT during EP study, the presence of multiple accessory pathways, demonstration of the capability of the accessory pathway to allow rapid conduction to the ventricle, and with non-invasive testing, identification of an abrupt and complete normalization of the PR interval with loss of the delta wave during exercise testing or following prokenamide infusion. The other last thing is intermittent loss of pre-excitation on a resting ECG or an ambulatory monitor has been also associated with a low risk of sudden cardiac death. In the last two slides, these are key messages from the guidelines of the European Society of Cardiology about the management of SVT. Thank you very much for following this presentation, and best of luck.